Welcome to the SNIS industry-sponsored webinar from Imperative Care. Today we have ADAPT 2.0, the next advancement in stroke thrombectomy. My name is Dr. James Milburn from the Ochsner Clinic in New Orleans, and I'll serve as the moderator for today's event. We have two great speakers. First, Dr. Imran Chaudhry is a very well-known interventional neuroradiologist. He was instrumental, as many of you know, in the development of the first iteration of what we call ADAPT, a direct aspiration first pass thrombectomy, as he was the senior author on this landmark publication, right, Imran, in 2013, with a very well-known graphic that is, that was cover art, and it's been in my lectures to fellows and residents for really ever since about how to perform this contact aspiration ADAPT technique. And Imran's an interventional neuroradiologist at Prisma Health in Greenville, North Carolina. He's has been professor at MUSC, and he's the fellowship program director at Prisma Health. We also have Dr. Hakeem Shakir, who's an endovascular neurosurgeon and an assistant professor at the University of Oklahoma. He performed his neurointerventional training at University of Buffalo, finished in 2018, just told me, at the Gates Vascular Institute. Great place. So today we're going to hear discussions about the evolution of mechanical thrombectomy and ADAPT, and then we're going to review recently published trial data, the MEVO trials, including what was published post hoc from the Imperative trial. And then we're going to discuss new advancements in aspiration of what has been, or what's being introduced as ADAPT 2.0. And we want to then have a real fruitful question and answer session. So please type your questions in the question box. You should be able to see that on your screen. And so let's just start it out, and let me pass it to Dr. Chaudhry to start our discussion.
Thanks, Jim. Appreciate the introduction. Just a minor correction, we're in South Carolina. There is a Greenville, North Carolina as well, but we're down a little further south. And then
it's all the same to most of them.
Yeah, it is pretty much all the same. And then, the whole ADAPT thing was really a group effort. It was really led by one of my partners, Quill Turk. I was happy to participate, but I want to give respect to where it's due. And it was really Quill who kind of came up with the idea with one of our fellows. And it was really a group effort in the evolution of the technology. And that's really what we're kind of talking about, right? Like the whole evolution of mechanical thrombectomy. And so, just to kind of review, stroke thrombectomy has been around for a while, starting in early, 2008 with the Mercy concentric retriever. There was, a big gap in any kind of evolution or new products for a while, probably about 5 or 6 years. And then, stent retrievers kind of came out in 2011, 2012. From there, we moved from stent retrievers to a combined approach to Celumbra, utilizing aspiration and stent retrievers. And then kind of inadvertently, we came up with aspiration thrombectomy by itself in 2013. And then 2015, there were multiple publications that kind of supported mechanical thrombectomy. And from that time, there's been significant improvements in the procedure itself, from not only a technique standpoint, but also as technology as well. And so if we could kind of go to the next slide, just in basic review, ADAPT, as Dr. Milburn mentioned, is a first pass aspiration thrombectomy technique. And the idea of first pass, meaning it opens the door to other therapies if needed. It's not exclusive to any one company or technique. And there's different techniques with this. It started with a triaxial system, a guide catheter, aspiration catheter, microcatheter, and a wire, getting to the clot and maybe going through the clot, and then utilizing that aspiration catheter for thrombectomy. And as I mentioned, there's been significant evolution in the technique itself, whether it's triaxial, coaxial, a wire alone, or snaking. And that evolution is, across the board, individual as well societal. I think we all have our own path in this. For a long time, I was triaxial, slowly moved to coaxial. And it was one of my partners who'd started snaking the catheters and was, hey, this really works most of the time, and it's pretty safe, efficient, and we're not really wasting time or losing time by doing it. So I think one of the things I want to highlight is, this path and the evolution is also very individualized. And part of the next stage of the evolution of thrombectomy was actually iterations in guide catheters, right? So we've all talked about the superbore guides. Traditional guide catheters were designed only to go to the distal cervical and maybe to the Peter segment. Advances in catheter technology, especially in these large bore catheters, allowed us to get to the intracranial circulations, specifically the cavernous, and then up into the M1. And there were significant advantages with this. Guide catheters in the cervical segment have a lot of the to and fro movement, up and down bouncing, which creates a lot of vasospasm and puts vessels at risk for dissection. Advancing the catheter in the cavernous segment is super safe. We use geometric anchoring, so it locks that catheter in place. And then also, these catheters are matched to the vessel size. So there's some advantages because you've already traversed a lot of the hostile anatomy. You have a stable platform to reaccess if you have to. You also have advantages of flow arrest because the catheter is matched to the vessel size. There's some reduction in flow, which probably improves our ability to remove that clot with aspiration and even with stent retrievers. And if we go to the next slide, please. Maybe. Yep. And so in that evolution, right, all the companies have kind of done their studies. And so we actually studied the Zoom system in a real world setting. And what they found is that their improvements in catheter technology, not only guide catheter, as well as the bevel tip, had significant improvements in our ability to perform this procedure. Out of all the studies so far and to date, they had one of the best and fastest reperfusion times at 19 minutes. I know for us personally, our average time before converting to the Zoom system was about 28 minutes, and we're down to about 19 minutes now as well. Our rescue rate with stent retrievers, the study showed a 4.7% rescue rate for secondary devices, mainly stent retrievers, and even additional catheters, right? And so for us personally, we were hovering about 22% before converting to the Zoom system, and we're down to about 9%. So there's significant improvements there as well. And this study also highlighted that this is real world anatomy. Almost a quarter of all arches were fairly hostile, type 3 arches, which can be really challenging, which speaks to the stability of the system. They were able to navigate across the arch, have a stable platform, which allowed us to access the distal intracranial circulation, allowed us to remove that clot. And then we're able to do it safely, or they were able to do it safely, right? Less than 0.5% serious vessel injury, dissections, or vessel perforation. And then the safety profile of less than 1% symptomatic intracranial hemorrhage was on par and better than most of the other previous studies. If we go to the next slide. Right. And then one of the most recent kind of questions has become the MEVO-DEVO question. Recent studies suggest that medical therapy may be as good as intervention, but I think there are some criticisms of the current studies. One largely being that baseline NIH stroke scales was relatively low, and the majority of these patients were treated with stent retrievers. I think utilizing a stent retriever distally, there's probably disruption of a lot of the small perforator vessels, which probably contributed to a decline in their outcomes, as well as an increase in the symptomatic hemorrhage rate. Utilizing a aspiration system probably mitigates a lot of the displacement of the vessels as you pull like a stent retriever. So we're limiting, disruption of those perforators, which probably improved the symptomatic hemorrhage rate. When we look at a small cohort of patients that kind of matched the escape MEVO and the distal studies. If we kind of look at the slide, the cohort here had a higher NIH kind of cutoff, 13, which is probably more representative of a more severe stroke, where TPA or tenecteplase is not likely to be as effective. Obviously, this was all aspiration, and we can see that with the aspiration, better rates of reperfusion, better rates of outcome, and lower rates of symptomatic hemorrhage, which kind of highlight some of the advantages of this system. So I think the discussion for MEVO-DEVOs is still out there. I know it's definitely impacted our practice a little bit. We're a little bit more selective. We're still treating these patients. Slide, please. Next slide. Yeah, and so kind of going back to our evolution, right? So, the Zoom study or the imperative study was kind of with the Zoom 110, Zoom support, and the Zoom 71. And there's been further evolution in their portfolio, which kind of highlights this new ADAPT 2.0. There have been improvements in intracranial access, which actually starts at the arch. The asymmetric or the bevel tip has some implications for aspiration. And then now this continuous dual aspiration technique known as CDAT also kind of addresses one of the limitations of the traditional aspiration system, which is namely the syringe on the guide catheter, dislodging the clot. And we'll show some videos of how CDAT can actually be effective. Next slide. So kind of starting with some of the improvements in the portfolio. I think this largely starts with their insert diagnostic catheters, these three catheters, the Zoom Sim, the VTK, and the VRT, combined with their intracranial access 88 guide catheters. The inserts have really changed the way we approach stroke. We used to have to leave the insert down low, kind of advance everything. These catheters now are able to advance all the way up into the distal cervical carotid. The shapes are super versatile. For the most part, almost 100% of our cases we use with the Zoom VTK. It works in type 1, type 2, type 3 arches, even in type 2, type 3 bovine arches with like kind of a swinging carotid. It seats really well, provides stability and a platform for you to advance your guide catheter up there. I think we all know in our world, access is the name of the game. If you can't get there, the rest of the procedure is over. So this is really where it starts, and I think this is one of the biggest improvements in the technique of aspiration thrombectomy. And then if we move on to the rest of the portfolio, the next slide, I think one of the things that a lot of the other companies have failed to do is provide a complete system. And I think we do need that system to chase distal clot. It's not uncommon that we have to go to M2, M3 to chase other clots, and I think having a complete system speaks to the dedication that that Imperative has placed behind their portfolio. And then within this, they have novel improvements. The bevel tip has implications for aspiration that we'll show in a minute here. And then also now the new Zoom 7X. And on the next slide, we're going to show that little offset, it's a 36-degree offset pre-shaped curve that basically kind of sets the catheter into the center of the vessel and allows it to navigate in an atraumatic fashion around these turns. And the video here is going to highlight over a wire how that bevel tip kind of reorients itself as it goes around these turns into a favorable orientation. So you're almost never catching, almost never, nothing's 100%, except for death. And we wouldn't want to talk about that in stroke cases, but it kind of highlights the advantages of that tip, how it atraumatically navigates around these turns, and it kind of orients itself in a very favorable fashion. And then the next video is going to kind of highlight how the ingestion is a little bit different. With a flat tip catheter, it kind of mushroom corks on the distal tip. The bevel tip actually allows it to ingest the clot in a more favorable fashion. And that's what we've been seeing when we kind of look at what we get in our pod, that we're seeing more ingestion of the clot rather than corking of the clot. If we go to the next slide, we're going to talk about the next stage, which is the evolution of CDAT, or the dual port. Right? And this kind of tried to address one of the big questions or problems that we've had, which was dislodging the clot as you pull that aspiration catheter back into your guide. If the clot was corked, a lot of times it would shear off. And if you only had a syringe on, you'd lose the aspiration force of the syringe. Personally, I've never used a locking syringe, but I would just leave the 2E open and we have bleed back. But even then, you don't really have aspiration pressure or aspiration force sucking that clot, and you would lose that clot. And so now using a dual port canister, and we'll show you some videos of how this works on a benchtop, and then we'll have a case that kind of highlights this as well. So, this video here is going to kind of highlight the conventional system. We're utilizing a single canister, the aspiration system, a pod, and a syringe. As you pull that clot back, the clot's engaged, it's corked there on the distal catheter tip. As we pull back to the guide, we kind of lose it. The syringe is kind of holding it there for a second, but the minute the catheter comes out, you lose that aspiration force and the clot goes flying distally. And this here also kind of highlights the same thing, just showing that you lose your aspiration pressure as soon as the 2E opens. You can see our numbers drop down to 0, so you've lost that vacuum. Now, see that utilizing a dual port and dual pods, kind of changes that. So same setup, you have your 71 with the clot corked there on the distal part, you're pulling it back, engages the guide catheter, we've kind of dislodged it, but we can see that, we haven't lost our aspiration force. The catheter comes out, you close the TUI, you still have aspiration pressure, you leave it, and it eventually ingests. Now, in a real world setting, I'd be pulling the guide back until I get flow. And again, here with the pressure gauge, it kind of highlights the same thing. We can't see it very well, but it shows that it maintains the aspiration pressure. And that's going to be shown here on the next slide with the graph, which that orange line kind of highlights that you have persistent or continuous stable aspiration pressure on both your guide and the aspiration catheter. While utilizing a syringe, the aspiration pressure drops to zero, and you kind of lose that aspiration force as well. And then I think the next slide is the case that kind of just highlights a real world setting. This is a case that we did a few days ago. We've obviously kind of cropped this a little bit, but you can kind of see the timestamp there. This case was a 20-minute left M1 occlusion. So we've got our insert here up into the common carotid. We're snaking our guide up over the insert catheter. Here's our first run showing that M1 occlusion. If you look at that bottom left, we can see our Zoom 7X being snaked up to the clot interface. And I think one of the big changes here in the technique is we used to talk about kissing the clot. And I think it was actually Jim here, Dr. Milburn, who described French kissing the clot. And it's really changed the technique, largely because I don't think we really know where the true clot interface. There may be a stagnant column of blood that's before the clot that you can't really identify the clot. And so that French kissing or kissing through or moving through the clot makes a lot of sense, because that way you know that you've kind of engulfed or ingested that clot. So after our first pass, you can see that we've got a little bit of recanalization there in the M1. Actually, we're not there yet, but this is just kind of highlighting the old technique, right? I'm still looking at the pod and the flow. So when I get my flow back, I remove that. I'm aspirating my guide, making sure that's clear. I do my run. We had partial recan of the M1. We're now going back up with the Zoom 55 over a wire, so a little change in the technique. But now with the 55, because the caliber of the vessel has changed, we're able to kind of push through the clot interface a little bit more. And we're setting up, both pods here, one on the guide and one on the aspiration catheter. And then we do our run after pulling it back, and we have Tiki 3 flow after 2 passes. And we can't really see that timestamp clearly, but I think this was a 20 or 21-minute case, start to finish. So it just kind of highlights, the overall technique and the evolution of the technique, right? We can see different parts of it where we've snaked the catheter. We're still using a wire, but one of the big changes is using that dual port with the 2 pods, and the technique there is roughly the same, right? I'm still setting one port to the aspiration catheter, the second port to the guide catheter. I'm closing the TUI when I pull back, so there is some resistance to the aspiration catheter, but as soon as we remove the aspiration catheter, I'm closing that TUI to maintain the aspiration pressure, and then pulling my guide catheter back until I get flow back, and then we're obviously checking both pods. And interestingly, in this case, what we saw was in the first pass, we had clot in the aspiration pod, and in the second pass of the Zoom 55, we had no clot in the aspiration catheter pod, but we had clot in the guide catheter pod. And we've actually looked back at our case series as well, and roughly about a third of all cases that we do with duoport, there's actually clot in the guide catheter pod, which is kind of interesting. I think that just tells us and highlights our need for better understanding of aspiration and thrombectomy in general. We're probably leaving a little bit of micro clot distally somewhere, not capturing all of it. And I think there's probably some element of improvement that we need to focus on with the technique and with devices as well. But there have been significant improvements overall. So
Imran, maybe I could jump in and just ask a couple questions, because we already have one or two related to this this part of the technique.
Yeah.
The dual aspiration to me just makes so much sense, and it's really well shown by these videos. It only takes a split second to potentially lose the clot at the face as the force drops. As air is sucked into the RHV. If you have a locking syringe, or we don't really think about it, but these videos I think do a great job. So when do you recommend turning on? Do you turn them both on at the same time, or I think in one of these videos it kind of showed turning on the RHV kind of right at the end. Is there any downside to just turning them both on at the same time?
No, I mean, it's really just it's a management thing, right? It's line management. So as soon as I get to the client interface, I've got my aspiration catheter there. I set that to the pod. I turn that pump on right away. I open up the little valve there, and then I connect my second pod to the guide catheter. I open it, and I open the TUI, the three-way, so that's under aspiration immediately. And then I usually wait for about a minute until I pull my aspiration catheter back. They're both under aspiration. Pull that back with the TUI kind of closed. And then just as I get to the end, you have to open the TUI, otherwise you'll stretch the distal tip of the catheter. So I open the TUI for just a brief second, and then keep the guide under continuous aspiration. And then once I get blood return in the aspiration in the guide catheter, then I'll take that off and check the pod. But yeah, there's no disadvantage to doing it immediately. It's more of just I don't have a second set of hands to turn it on at the same time.
Right. Good.
I think it's just real quick. I like to put it on early because personally, I don't want to forget. Right. I just if the sooner you do it, the less you have to, remember things during the procedure. So it's nice to do it earlier, and that's kind of prevented me from being like, oh, I gotta, put this on, and maybe you forget sometimes. So
I think that's one of the best reasons, as long as there's not a downside to doing it early, which I mean, there's just not that much aspiration that can occur until because there's, they're so close in size. There's just not a lot of dead space there. And then Dr. Shaw put in the chat here, have you seen any additional blood loss with CDAT, particularly through the 88? And I think the answer is no.
And if anything, it's probably less, right? Because with the traditional syringe, I was probably aspirating the 20 cc's of the syringe, probably again. So there's probably 40 cc's of blood loss right there from the guide catheter just to clear it. With this, it's probably a fraction of that.
I guess there's another question I'd like to ask. What about you talked about floating the large bore catheter, to 7x, and I know a lot of people are doing that. A lot of people aren't doing it. I can see reasons to do it and then questions, but I mean, is it the time savings, just having just one catheter to manipulate, or is it just the setup? Obviously the setup is way easier for your tech and everybody else, or is it, or I guess another possibility is if you're advancing a wire and a smaller microcatheter, those I think would be the most likely to push clot, because a lot of times you're going through it, and if you don't have to, maybe, do you notice a difference in clot migration? I mean,
I think there probably is some element of clot migration when you disrupt it with the microcatheter. I'm not adamant about it, right? Because I think the biggest thing is you've got to get there. So sometimes if you need the stability of the triaxial system, you got to do what you got to do. But I think the answer is really in the simplicity of the system, right? Like with one catheter, I don't have to worry about triaxial systems, pulling a microcatheter off the wall to get it across the ophthalmic and things like that. It's a very simple float. You can see there's nothing in the back. I leave it open just so that there's blood back and I'm not pushing anything. So the one, simplicity of the system. Two, cost savings. It doesn't take me, I don't have to worry about the cost of a microcatheter, a microwire, things like that. And then, if I have to, I mean, the time, you can see this in 20 minutes, I'm still able to pull out a second catheter and a microcatheter or a microwire if I need it. So, people who argue, oh, I just want to go up there because of the time savings, just one and done. I mean, let's be real, right? Like 90% of the time things work great, and 10% you're going to be pulling out additional stuff. And the overall time savings, cost savings, there's significant advantages for that. And the simplicity, even from a tech standpoint, setup standpoint, you have rotating techs. It's not hard to mess up. Just give me a catheter. It's hard to mess up. Do you want a TUI on this? Do you want a co-pilot on this? Do you want a flush line? How do I set this up? What wire? None of that. All that goes away. It's just super simple.
yeah, it's just super fast. I think the techs here, they love the fact that less product is opened. I even tell them now, just don't even open. Used to have an Aristotle or a wire, initially opened up. I've started to say, like, let's just hold off on that for the first pass and see if we can do this without opening up that extra product. And they really appreciate that. And I think when you can get up to a M1 with 2 catheters in under 10 minutes, I mean, you win the room. You've done a service to the patient. The hospital loves you. So, I mean, to echo everything that Imran said, I think it's a great technique, but obviously, I think, it has to be done within the confines of the comfort level of the provider, right? So if somebody likes having a microcatheter or having an obturator device, I think you have to do what you're comfortable with. But it works, and I think both of us can attest to the fact that it works without having a large wire and or obturator device or microcatheter.
I think you really hit the nail on the head there. I think it's an evolution for each of us, right? Like I said, I was a triaxial person, then moved to coaxial, and then largely during the trial, I was a 71 with a wire, and then slowly kind of migrated to just snaking it. So I think it all comes down to personal comfort. I don't think anybody's advocating go out and just snake this up there from the get-go. I think you highlighted that perfectly with it's a skill level, a comfort level.
And what it also, I mean, another point that you brought up is that even if it doesn't work, or even if you don't get that, that Tiki 3 in under 10 minutes, the beautiful thing about this system and what's changed my practice is that you're already still up there, right? Your 88's right there to reload and to get a 55 or something, if you have to go distal, you're primed and ready, and you can have your techs open up whatever they have to. But again, it's a great system. I think when you use it in that fashion, you really get wonderful results.
Mm-hmm.
And you find a significant improvement. It makes so much sense with the 7X over just the 71, just the orientation. It just, it takes away a lot of the potential questions people would have about the lip and the ophthalmic and stuff, which I don't find to be a problem anyway, but I mean, too often, if you do it quick.
I think Dr. Shakir is going to share some videos highlighting how well this navigates around ophthalmics and even big peak humps as well.
All right. Well, do you want to move forward then? We'll go do some cases.
Yeah, let's jump into the fun stuff. So this is a right M1 occlusion. Again, simplicity of the system, right? You just have 4 products total if you really get to it, right? 88 support, in this case, 7X, the SIM to get there, and then that 035 glide. So right now, cost of case is well below $8,000, $6,000, I think. But a stent retriever, just so everybody knows, is $6,000 to $8,000. But if we could show the next, right? And here you can see, in this cine capture here, where the 88 is, and soon to see where the 7X goes. Yep, there it goes. Almost kind of effortlessly. I hate to, I mean, it's rare that I like to, drink Kool-Aid of a product, but this one definitely earns it, because look at the PCOM on that lateral. So I was very skeptical about this and its responsiveness around the siphon, around a big PCOM like that. And again, the 36-degree angle, the bevel tip, it just beautifully passes by, and you get excellent recanalization. Next slide. So again, a beautiful radiographic Tiki 3, Tiki 2C kind of result here. Yep, and there's the picture of the clot. I'm not sure from which pod that came from, but again, there it is. All right, so left-sided, same kind of setup. This must be one of mine because I see the Aristotle 024 in there. But yes, again, 88 support, 7X, 035 glide, and an 024 Aristotle here. So let's go to the next cine video here. So again, where you have your Zoom 88, as this video shows, is important. That makes a difference. That gives you that support. And there you see a knuckled 024 Aristotle wire. Many people like to knuckle their wire aggressively so that it doesn't spear the clot or perforate a vessel, and I think that's fine. And here's the part where you can see that 88 kind of retracting back as you push the 71. And that's where you talk about French kissing the clot. I know Dr. Milburn was recently in France, so that's why that's so fresh, is that French kissing. And I really like that term because you really have to wedge that. And I think there's been studies that show that where the actual radiographic clot is versus where the in vivo clot can vary, right? So I think it's important for people who use aspiration to be comfortable pushing it just a little bit more distal than they were maybe conventionally taught years ago. And that's your recanalization. Do we have any questions? Yeah, and again, this picture here shows the clot captured in both pods, right? So that's something, Dr. Imran Chowdhury just commented on, was the fact that he's seeing, I think you said, Imran, in a third of your cases, you're seeing clot within the 88 pod. Yeah, I'd say more and more we're seeing little fragments and debris in the 88, which makes me wonder, for all these years that we've been doing aspiration, how much ENT could have been prevented and how much debris has been, shot up distally to other territories and other vessels. So that's why, again, I personally went from putting the 88 pod on later to now doing it almost simultaneously or right after it goes on the 7X or the 71.
Yeah, those are great points. There's a question here. How long do you keep aspiration on? I know it probably varies by the case. It certainly does for me. And
depends what time of day, maybe. I'm kidding. So I think the recommended, and I think the right way to do it is to really give it 2.5 to 3 minutes if you really want to give it the chance for clot ingestion, right? So that's what's going to give you, it needs that time to, and again, some of these clots maybe have been softened by TNK, and I think to give it the best shot, you have to at least try over 2 minutes, as painful as that might be to some people, especially those who have a need for speed. And I defer to you guys and your expertise on that question.
Yeah, sometimes it comes out right away. Yeah. Go ahead.
Yeah, I think time is definitely important. Somewhere between 1 minute to 3 minutes is probably ideal. In addition to that, I think it's also a very slow pullback on the aspiration catheter, not just ripping it out, but probably a slow pullback, which gives you less chance of dislodging that clot if it works, or giving you more time to kind of work. And I think that's important because as you come back, I do think that you need some blood flow around the aspiration catheter to help force that ingestion. And so as you pull back slowly, it just gives it more time to work as well.
I have a question actually for both of you here. What is your strategy with the 88? Are you always trying to, because I'm always trying to see how high I can climb that 88, if it's not the support, obviously, to the terminus and even to the M1 if possible. And Imran, I don't know if you can talk to that particular point, because there is a component of being subocclusive within the ICAT and the M1 with the 88.
Yeah. As I pull back on the aspiration catheter, I let the 88 ride up as high as it'll go, for a couple of reasons. One, I think a little reduction in flow is probably advantageous, so you don't dislodge the clot. Two, less distance that you have to pull the clot back into the guide catheter, so less distance. Likely, if you're getting an MTA or carotid terminus, less turns, where I think your aspiration catheter is probably going to whip around in the turns and possibly break off that clot. So there's multiple reasons, but I just do it naturally. I don't force it. My goal is not to get it to the M1. My goal is just to let it go as high as it'll go with no force of the gun. And that just, I think, makes everything a lot easier.
And I do appreciate the fact that you said pull back slow. I used to be, I'm guilty of pulling it out way too fast. And I think in many cases in my early, years, probably losing or not getting adequate reperfusion recanalization because I was too hasty in getting that catheter out.
Yeah. one thing, when I do get the, the first catheter, whatever my primary aspiration catheter, if I'm leaving it there for a long time, 3 minutes is a long time. I'm proud of you guys for leaving it that long. That's very difficult, but I think a minute and a half is pretty good. But I don't just leave it sitting there necessarily. I'm kind of moving it a little bit back and forth, because you never know if just changing the way it's hitting the wall might help it aspirate. And I think I think a lot of people, when they start doing aspiration, they're not taking it, like you said, not taking it far enough. They're taking it to where the contrast ends, but really you might not be at the clot yet. And I think that's where a lot of people fail with aspiration early in their careers, because they're not taking it. They're just not, they're a little afraid to push it kind of into the clot more, but you really need to get it married in there pretty deeply. As far as the 88, how high to take it, what I do is, I first get like my 71 where it goes, and then I'll just take it and ride it up until it just stops going. And if it goes to the M1, hey, that's great, because then there's no chance of losing a clot into the ACA, and studies have shown, and nice studies, benchtop studies show that the higher you get this, the more of like a balloon guide effect you get. And if you get it to the supraclinoid, basically you get it like a balloon, that the same amount of flow arrest as a balloon guide. And if you get it to the M1, it's actually beyond what a balloon guide would do, because you don't have any other potential flow coming in. So that's what I do. But I don't, if it's a big high posterior, turn of the cavernous, and it's doesn't want to go, I don't try to force it around. I just take it as far as it kind of goes fairly easily. I know a lot of people say they get it there 100% of the time to the M1. I don't think that's really that important, and I don't think I think it's good to do when you can, but I don't fight it to get it there. That's my techniques. So you want to go on, show some more cases? I think you're
Turn
muted.
my mic back on. Yeah. So another left M1 occlusion. Again, you're seeing the simplicity of the system, and I think my recommendation is subscribe to the system. I love using them all together as a platform. I think that's really kind of made a difference, at least as far as I can tell anecdotally. So again, you're seeing the simplistic nature of this setup. It's a proximal M1, and you're seeing the VTK select the left common here. Yeah, so again, I think this is going to show, snaking up or floating the, it was fast. That's the thing. It happened. It happened so fast. You have to be careful. I mean, that happened faster than I was prepared. But again, you can see where the radiographic cutoff is. And I think this is the takeaway from this particular slide, is that notice the radiographic cutoff, and look at where the distal tip of the 7X is located. It's well beyond, I would say almost like a centimeter beyond where the actual radiographic cutoff is. Again, going back to a point that we talked about, where the clot begins and where the clot ends is a debate. And so I think getting past it and maybe doing a little Hoover vacuum type of maneuver like Dr. Milburn was suggesting, kind of maybe massaging it back and forth a little bit, having it interact with the clot differently, that will help achieve a better recanalization on the first pass. I think there's some nuance to this technique. And I would say after doing, I don't know how many hundreds of aspirations, getting past the radiographic cutoff is advantageous. Next. Yeah, and again, it's a beautiful picture. And I don't have the actual timestamps. They blocked them out. So this had to have been done, I would imagine, in under 10 minutes. I don't have the actual timestamps here, but when you don't have to have a microcatheter, when you don't have to have a obturator or even a wire in this case, your times are going to be sub 10 minutes. All right. So we're showing a right-sided access. I'm not quite sure what kind of arch this is here, but I think, Imran, I don't know if this is your case.
Yeah, I think it was like a type 1, type 2 arch. It wasn't terribly challenging. And then obviously again, VTK. The old VTKs I used to leave at the arch. Nice thing with this system is you can float the 88 up over the wire with the VTK down low. You can actually navigate the VTK up high. In the old days, we used to have to split the planes to kind of see the arch and then the bifurcation. It's nice because it kind of all floats up and you can not have to change your system. For me, one of the keys is, I'll just put the wire up and just kind of float this system. My goal is to kind of push it up to the posterior genu at the first go. And you can see even without the wire there up around the Peter cavernous turn, it goes very easily. Even the 88 goes very easily around those. And I think you highlighted also, like the stability comes from placing it intracranially, or at least at the cavernous, the posterior junction. It's really what my goal is, and that just provides stability for pushing the other aspiration catheters up there. And if you go to the next slide, I think this is going to show, yeah, there's a big PCOM here and a fairly sizable ophthalmic. And I was like, there's no way this is going to go. And if you look at the video, hopefully it plays kind of real time without jerking. You can actually see the tip orient in different directions, and even go around the big PCOM there very easily. I guess we don't have that. And
You're
even
so fast. You're going too fast.
Yeah, we'll have to leave those comments aside, but I think some of that's the video. Some of it is definitely, I tend to get a little bit quick on my push, but a lot of it is because it floats up there.
Yeah.
It really does.
And it tolerates that push very well.
Yeah. And the thing is, I'm not pushing against resistance, right? We're not being silly and pushing against resistance, like even pushing through the clot. Like I've never really seen an aspiration catheter perforate a vessel because it went blindly, right? If it perforates, it's because somebody's pushing aggressively against resistance and all of a sudden it's jumping. Like I will load a catheter, but if you're pushing and you don't see any movement, it's a sign to stop. If you're pushing and you see advancement, it's going to follow very atraumatically the course of the vessel. So I think this here, pushing through the clot, we don't have to worry about it. Like pushing against resistance, that's, I hate to say stupidity, right? But it's all these catheters are relatively atraumatic. If it catches, you got to stop and readjust. But otherwise, it floats very easily. And
yeah, Imran, can I mention something with that? I think one problem that new people who are just starting out in their careers have is they take it part of the way and then they get a little nervous and they stop and then they try to restart. That's the worst thing you can do. If a catheter is moving and moving well, just let it continue to go and it's going to find the spot, right? And it's if you kind of keep stopping and then it's real hard to get started again, and that's when things lodge against the ophthalmic and stuff. And if you just kind of go, you can pretty much do it on the AP plane almost, because it goes so easily, and that's what you guys are kind of showing. But I'm just pointing this out for people who are starting in their careers. I think this is something you have to coach people.
I think you've got to trust the technology.
Yeah, and I think one of the other things this highlights is, moving from a triaxial system or even like an obturator system. I think there's like this psychological, I almost want to say benefit of like a triaxial or an obturator system where, all right, I don't have a lip, I'm not going to get caught, and it's going to float. But all those catheters and devices have issues, right? There's increased cost. They limit your microwire down to a 14 system. You've got to open up a second system. You're already paying for a second catheter, the insert catheter to get your catheter up there, but I can't do anything with it, And then I think this is kind of showing that I no longer have that psychological like fear that I'm going to get caught. And even if I do, it doesn't bother me. It takes 30 seconds to open up a wire and I can still get up there and go.
Agree.
There's a couple of questions that are actually pertinent right now. So one, we're talking about pushing catheters through vessels. Do you ever encounter vasospasm, especially if you're bringing the 88 up?
If I have, it's mild and usually resolved by the end of the case, and nothing a little verapamil can't fix or handle. So the vasospasm concern, again, these catheters were designed in such a fashion that they're very atraumatic and very well tolerated by the vessels. And I think Imran would attest and agree, and Dr. Milburn, that your rate of vasospasm is probably minimal at best.
It's almost rare to see vasospasm beyond the petrous, in the petrous carotid and beyond. In the internal carotid, MCA, definitely you can have some spasm, distal vessels, reactive. More spasm that I see is when I have a guide catheter in the cervical carotid, because of all that movement, you're going to irritate the vessel. I mean, like, how many times in a diagnostic, when you don't have the catheter tip oriented in the right way, you've got spasm in the cervical carotid? You almost rarely see that spasm progress up into the intrarenal circulation. So like Hakeem said, it's atraumatic. The geometric anchoring favors placing it distally. You mitigate the vasospasm risk. And even if there is a vasospasm, who cares? You got an M1 occlusion, right? Like, I'm worried about that. And like Dr. Shakir said, by the end of the case, it's resolved, or you give a little verapamil and it's gone.
It has the effect of a balloon guide.
Yeah, right. Yeah.
There's another question. That's what I always tell the fellow. It's like, don't worry about it. Another question, can you manipulate the 7X by turning it, and how much does it translate when you turn it? I don't really think you turn it so much, but
you can't torque it per se. If it's ever oriented the wrong way, you can pull it out or pull it back. And largely, I'll just take it out and then re-advance it, and just placing it back in. A lot of the times it's in a different configuration, and then it'll go. But you can't torque it.
changing the catheter that it's in, like the 88,
Right.
changing the position of that will kind of make it go into the vessel a little bit different.
Yeah, advancing the 88 even higher, it'll change the inflection point around the turn, and that may change the angle of interaction with the ophthalmic or the PCOM. You can definitely do that as well.
Yeah, great. Okay, that's all the questions right now.
Yeah, let's go to the next slide. Oh yeah, this is a great one. So yeah, this is if we're showing the tandem occlusion, this is one of the great advantages of having dual aspiration and both pods, because you can see the clot burden that has been yielded in them. And so again, there are so many merits to having continuous dual aspiration, and this is a great case for that. It looks like, again, it's a little bit cut off here for me, but the Zoom 88 support was used, and that's kind of what the go-to is, at least for me, and I think Dr. Chowdhury and Dr. Milburn here. Anytime we're doing tandems, go with the 88. I think you're seeing, for the viewers at home and elsewhere, you see that there's kind of maybe a mix and match between 88 support and 88 regular. I think whenever you're doing any kind of proximal work, support will be the better choice. When you're trying to go distal, I think the traditional 88 is the way to go. But yeah, this is one of those perfect examples of having dual aspiration in a tandem occlusion, and look at that amount of clot burden that was ingested. It's just it's amazing.
Yeah, and the support is still very soft at the tip. It's just got it just doesn't have as long of a soft tip, so it'll stay there proximally for you.
Now this is another case example. I think this is Imran's case, an M2 occlusion that required a Zoom 35 to be opened up here. And I've had this happen before, where the initial setup is a 88.7X or 88.71, and then there may be an M2 that has to be chased after. The great thing about having a system and using the system and subscribing to the system is that the 35 is right there, ready to be opened up, and can be taken easily if you have good intracranial access, which is through the 88, and taken into the distal M2s for those, ticky 2Bs, and you want to get a better recan, you're able to do that. Really ticky 2As, I should say.
I think this also kind of highlights the advantage of the CDAT, right? If you look at the pods, the Zoom 35 has no clot, the 88 has clot. And kind of in reviewing our data, it was interesting that it's not a huge number yet, so I can't say there's a trend, but there may be a little suggestion with the smaller catheters that we're actually seeing more clot in the 88 pod than in the actual aspiration catheter, which means that it's probably corked at the end. We're losing it at some point, and it's really important to aspirate the guide, especially when we're chasing distal clot. I think this highlights that in a big way.
So to look at this slide here, I think we're reaching kind of the end here, or nearing the end. You can see, again, the procedure time comparatively to other major trials that have been done in the past decade. And again, the puncture to final angio median time is 15 minutes, right? So this is fast. And I mean, we're joking about how fast the videos are, but it really is that fast. And I think everybody here would agree that whether you're using the float technique or whether you use a wire, I think the speed at which these cases are being done are, I'd say, almost exponentially faster than what I was accustomed to in my training. It's just really impressive. And, the fellow and the tech are always just, if it's over 20 minutes, people are really, really disappointed. I mean, if it's over 15 minutes, I think people are really disappointed. But the puncture to, recant times, again, I'm not going to go through each of the different studies here you're seeing, but there's a clear benefit and a clear difference with this system. So I don't know if Imran, you want to comment on how what it was back in the olden times. I wasn't a part of that era, but
I mean, I think Jim can speak to this as well, but in the original days of stroke, I mean, operating for 3 hours was not uncommon with like a Mercy retriever and a balloon and trying to, put something together. And then, we kind of evolved to like the golden hour, where an hour was a threshold of passes, and then, this surrogate of first pass efficacy. But really, I mean, I think it's time. And now, I think if a case takes longer than me to drive to the hospital, I think that's a sign that it's taken too long. And I think it highlights the significant advantages in the entire evolution of mechanical thrombectomy, right? Like the efforts that the companies have put in on the catheter technology, device technology, physicians, and our understanding of what it takes to actually do this. What are the true metrics? I think it just highlights the group's efforts to understand this better. And I think we're seeing the benefits of that, right? We're seeing that over time, the efforts that we've put in are finally coming to fruition with significantly faster operating times, better recan times, better clot ingestion, better outcomes, better safety profiles. And I think we're seeing that, in that last slide that you showed, it kind of highlights that beautifully all over, like, from the original studies showing improvements in time, like, your VECTA studies at 60 minutes to significant improvements. I don't think they have our safety endpoints here, but, that safety endpoints and even recan endpoints are improving. My only little nitpick is I think we've got to move past TICI 2B, and we've really got to focus on TICI 2C or better. I think that's one thing that I would think is the next iteration of our improvements. And then I think also, I'm not too worried about first pass efficacy. I think a lot of people kind of talk about that. I think it's a surrogate marker. You can't tell me that, with all the delays and out of hospital triage and care and in hospital triage, that the only metric that matters is first pass efficacy. No way. I think it's probably more better recan, patient selection, and probably time to recan.
Yeah.
Sorry, my little
Yeah,
secrets.
Imran, what you're saying, TICI 2C, but that may be the difference in, having a pretty good size M3 branch still out. And, and just for people to understand, I guess most people probably do, hopefully, that the trials looked at M3s and so forth, and the data kind of suggests that, we really should consider whether or not to treat those. But that was all primary M3s. M3s. That wasn't secondary M3s that occurred during a case. Those have never been studied. There's no evidence that we should not do those. And those studies have shown that those actually are worse than if it were just a primary M3, occlusion. So I still go after those if I can reach them, right? So that's where we're getting to the Tiki 2C or better.
Yeah.
By and if you have a 35 right there, it's it's a great catheter for that. You can cork some really good distal kind of sizable clots. Hakeem?
Yeah, I was going to say, this he commented on first pass effect. Sorry to interrupt, but I was talking to my fellow recently, and I said, and it's maybe my opinion here, I would rather have 2 passes with aspiration and no SICH, basically no subarach or any kind of contrast staining, as opposed to having a stent retriever out in an M2 and then having the post-op CT show some subarachnoid blood, as we know that, because I think those are significant, and I think people get really hung up on that first pass, and I again, it's maybe a hot topic to debate, but I think there's a lot of valor behind using aspiration and being safe, and maybe having to go back for an M2 sometimes with aspiration after you've opened up the M1, perhaps. I don't know how you guys feel about that, but again, I take a lot more pause now than I ever have opening up a stent retriever to go after an M2.
Yeah, definitely. I mean, there's pause, but at the end of the day, you still got to do it if you can't get it open.
Yeah, you got to open it. Sure.
The threshold is definitely very different in trying to get to that point. I will take 3, 4, 5, 6 passes before I get to that point. One of my partners did a case the other day. I think it was 10 passes, then finally stent retriever. But there was a lot of like nickel and diming, right? There was got the main branch, then there was a secondary branch in a different territory that was already previously included. So multiple passes, but ultimately required stent retrievers. So, I mean, yeah, I agree with you. Like, I'll do what I can not to, but there's still a bailout. And that's kind of highlighted in the study too, right? A 4% bailout rate, which shows even with the aspiration and your technique of chasing it with aspiration catheters, you still get a good result. And that Nevo Devos cohort highlights the safety implications as well.
Okay, we're close to an hour. I think we have time for a couple more questions. So with the Mevo Devo trials that came out, how have these changed each of your practices? Hakeem, you want to go first?
Yeah, I mean, I think when those trials came out, we definitely, as a group, collectively, started evaluating them more closely. Right? We went from the pendulum was open up everything all the time, and you had the last study, you had all these studies that were encouraging opening up the vessels. An opened up vessel is basically better than a closed vessel. And then you start looking at kind of the outcomes and the MRS, and then people are having debates over that. And then these Mevo studies came out. But I would say we collectively agree as a group that there's an inherent risk with bringing a stent retriever into an M2 and shredding endothelium. And you can see it. You can watch it when you're pulling a stent retriever back in the distal vasculature as the vessels bend and move, and there's sometimes I would say even some discomfort with that. And so what this system has allowed me to do is evolve towards pursuing a 35 aspiration catheter and taking it out before I grab the stent retriever, and has minimized contrast staining. I think is better and safer for the patient, and that again opens the door now for, well, we need to do a better job collecting data and studying what M2 will look like with just aspiration alone.
Yeah, Ron?
Yeah, I mean, the studies definitely impacted our practice in that we're probably a little bit more selective in our patient criteria. For me, significant findings, like if a patient has aphasia and it's an M3 occlusion, I'm definitely going after that. Somebody who has a stroke scale of probably 8 or more with a distal lesion, I'm probably going to go chase. people who are probably like what I like to call a soft 5. Maybe they have a point for an arm, a point for a leg, point for a face, and maybe a little dysarthria. Those they'll probably be a little bit less aggressive on, especially if they're an older patient. I'd say, hey, maybe this is better for Connect a Place or TPA. And a younger patient, depending on their situation, maybe go after it. But for the most part, I find that those patients with the softer scores tend to rehab fairly well without the risk of a surgery. But patients who have significant issues, I'm definitely going to be aggressive about. For me, aphasia it's a significant debilitating event. And so someone like that, I'm going to be a lot more aggressive with. And as a whole, I think that's kind of been the little shift in our practice, just being a little bit more careful about our selection. I think previously, much like Dr. Shakir, it was, if you call us, I'm going to do it. Kind of any and all comers we're going to open, but a little bit more selective in that group.
I would echo everything you said. I think that's exactly the way I kind of look at it in my practice too. With aphasia on the left, an M3, it's extremely important M3. So those I tend to go for. On the right side, they often just kind of get better on their own. Like you said, the soft ones. I mean, they so frequently get better on their own, and you can make them worse. So, I wonder. I always, when I think about these trials, the way the late presenters were proven, with the Dawn and so forth, it was all using perfusion. So we were using the best, choosing the best cases to look at. If we were looking at all comers and those without using perfusion, maybe those trials wouldn't have been positive either. I kind of wonder if we don't use perfusion at our shop. We just kind of go along more with the, Goyal's kind of denominator principle. We try to treat everybody and don't exclude any with perfusion. But I wonder if these trials might have been a little different if that was involved, if they really just picked out the ones where, because a lot of these patients might not have had any opportunity to get better, like there was no chance, and then you get a few complications and then you're not going to get positive trials. I'm not suggesting that trial necessarily, but I kind of wonder.
Yeah, that as well as the low aspect scores.
Absolutely. Well. Yeah, right, exactly. So, any other questions that, let's see, there's a couple other ones, but I think the other questions, like there's a question about VTK for access. Should the tip remain engaged at the ostium? You kind of mentioned that you used to always do that, but then now you kind of sometimes bring it up if you have to. Yeah. If you don't have to, I guess just leave it at the ostium.
Yeah, largely just so from a workflow, when I leave it down low, I put the A plane over the R's, B plane over the bifurcation, so I could just kind of go up in one pass. Now with the new VTK, it acts like a diagnostic insert. I bring it up into the common. I don't have to worry about the extra time to kind of split the planes. So, you can do whatever works for you in your workflow. It's a super versatile catheter, so it'll work however you want it to work.
Okay, I think there was one more question about CDAT. Any thoughts on the effectiveness of CDAT with an intracranial guide versus guide in the cervical carotid? You might get more flow if it's in the cervical, I guess. But.
Yeah, I don't think we know enough. And to be honest with you, that's probably not something I'm ever going to explore because my guide's always in the.
Me too.
Yeah, same. Got to take it up high.
Okay, well, we're past the hour. I think we could probably quit. Thank you, gentlemen. Thank you, Imperative, for putting this sponsored webinar on. Thanks, SNAS, of course. And Anthony for helping us out. Have a great week, everybody.
Thanks, guys.